So, as you are well aware, amblyopia is a clinically defined as unilateral or bilateral reduction in the best corrected visual acuity, which is caused by full vision deprivation and or abnormal binocular interaction without any visible organic cause. The visual acuity should be less than 612 for bilateral amblyopia, and there should be difference of more than 2 lines for unilateral amblyopia. And it is correctable if appropriate measures are applied at appropriate time. The diagnosis of amblyopia required evidence of reduced visual acuity, presence of amblyogenic factors, and no alternate cause for loss of vision. Various treatment modalities are available to treat amblyopia. A large magnitude of studies have been done, however, none of them is foolproof. In ATS-5 was conducted to evaluate effectiveness of refractive correction in moderate amblyopia, and it was concluded that amblyopia resolved in 27% of patients, and there was improvement of more than 2 lines in 77% patients with refractive correction only. In ATS-7, treatment of bilateral refractive amblyopia with spec corrections improved the binocular visual acuity. Then in ATS-1, penalization versus occlusion was compared, and it was aimed to compare the patching versus atropine penalization for treatment of moderate amblyopia in children of 3 to 7 years of age, and it was concluded both are appropriate modality for initial treatment of moderate amblyopia. And follow-up at 10 years of age shows improved visual acuity is maintained although residual amblyopia is common. There is no shortcut or substitute for occlusion in amblyopia therapy. However, variability exists in number of hours prescribed to treat amblyopic patients. Then in ATS-2A, full-time patching was compared with 6 hours patching in severe amblyopia, and they concluded that there is similar improvement in both the groups. And in ATS-2B, 2-hour patching was compared with 6 hours patching in moderate amblyopia, and they concluded both are equally effective treatment modality. Then in ATS-4, daily versus weekend atropine was compared, and they concluded weekend atropine produces an improvement in visual acuity which is similar to daily atropine. Then the question is when to start amblyopia therapy. It is better late than never. Is there any age bar to treat amblyopia? Whether amblyopia can be successfully treated in older age, ATS-3 was conducted, and they concluded treatment can improve visual acuity in older children also. Levodopa is a promising agent in augmenting the conventional occlusion. It speeds up the recovery of visual functions, improves the compliance, decreases the duration and cost of treatment. However, maximum achievable response, likely cases amenable to therapy are not clearly defined. ATS-14 and 17, they are being conducted. Near visual activities are often prescribed during patching for amblyopia based on the assumption that those activities they stimulate the visual system. ATS-6 was conducted with the aim to determine whether performing near activities while patching for amblyopia enhances the improvement in visual acuity, and they concluded performing common near activities does not improve visual outcome in treatment of amblyopia. However, other studies they are contrary to the recommendations of ATS-6. Television has been a very popular mode of entertainment. There has been general myth among common men that television viewing, and especially that too from too near, has been the cause of many eye problems, mainly of the refractive right. It is an effortless method of providing stimulus to an amblyopic eye in children, and it is easily accessible in every household. It has colossal influence in our lives, and it is formless with which the children watch it. It is a novel way of using in amblyopia therapy. In spite of its huge popularity, there has not been any long-term prospective studies using television games as a form of near visual activities in the amblyopia therapy. A study was conducted at our center in which television games they were tried in amblyopia therapy. These were the inclusion criteria. The patients were divided in 2 groups of 20 each. In group 1, occlusion therapy was given, and in group 2, occlusion along with television game exercises were given, and these were the games which were used. And it was concluded that mean line of improvement was more in the group B, that is television group along with patching, as compared to the only patching group. And we concluded that there was improvement in the distance visual acuity as well as near visual acuity in both the groups, but was found to be better in the television game group as compared to the full-time patching in treatment of amblyopia. And we recommend use of television games along with full-time occlusion in treatment of amblyopia. And then these video games has also been studied by Ghosh et al. And they also recommend. Then, is there any role of LASIK in anisometropic amblyopia? Another study was conducted at our center, and in this aim was to find out the improvement in visual acuity after LASIK surgery in adult and isometropic amblyopia to compare the mean spherical manifestation before and after the surgery. And in this study, only the desperate cases which were conventional therapy failure, they were included. These were the inclusion-exclusion criteria. These are the patient demographics. This is the bar diagram which shows mean value of pre and post-operative uncorrected and best corrected visual acuity. This is the pie diagram which shows the lines of improvement. And we recommend LASIK in desperate cases of anisometropic amblyopia. Then another study was conducted to evaluate the efficacy of 6 hours occlusion and television exercises in mild, moderate and severe amblyopia. These were the inclusion criteria, these were the exclusion criteria, these are the study designs. And it was concluded that 2 or more lines of improvement was present in 90% of the 90%, 70% and 67.7% patients in group A and B and C. Then another study is being conducted at our center regarding role of mobile game exercises as an adjunct to amblyopia therapy. These are the objectives of this study. And this study is based on Hess research, which says that amblyopia is a binocular problem and it is due to disruption of the binocular visual development. Another study is being conducted regarding role of omega fatty acids in treatment of amblyopia, and we are doing this pilot study of omega fatty acids in treatment of amblyopia based on antioxidant, anti-inflammatory, neuroprotective, anti-apoptotic, trophic stimulus and neural differential effects of omega fatty acids in treatment of amblyopia. Transmagnetic stimulation has been tried by Hess et al. From Canada, and they concluded 10 minutes of transmagnetic stimulation improves the vision in amblyopic eye. It does not change the normal eye vision. Acupuncture has been tried by Zhao et al. From China. Monocular telescopic devices has also been tried. Then another important step is which comes first, amblyopia or surgery. Classical teaching is amblyopia therapy should be given prior to the surgery, but you can continue with amblyopia therapy post-operatively also. So I would like to conclude, conventional occlusion is still treatment of choice, although part-time occlusion is gaining acceptance after ATS reports. Penalization is useful alternative therapy. Levodopa is promising augmenting agent, and near vision exercises, especially television games, are beneficial. LASIK should be tried in desperate cases of anisometropic amblyopia. Pleutics and stimulators, they are outdated. Thank you, Dr. Subhash.